All right. Good afternoon, team. MDC4. All right, this is week 8. You are doing your ATI medical surgical test. I already completed at this point if you're going to be watching this. And this is going to round up our last module before the exam number 2 coming up. So that's exciting. And this one is on MODS, inflammation, sepsis, DIC. So again, inflammatory immune responses, systemic inflammatory response syndrome, which is SIRS, sepsis, and disseminated intravascular coagulation or coagulopathy. You'll hear it either way. And multi-organ dysfunction syndrome or MODS. So let's start off with talking about the capillaries. And let me just get this. I have an issue with my WebEx. All right. So capillaries are the smallest blood vessels in the body. We know that. The walls consist of a single layer of flattened endothelial cells, the endothelia. And these cells continue the barrier between they constitute the barrier between the blood and the interstitial fluid. Capillary walls are permeable. We know that. Things go in and out of them. It allows for the movement of white blood cells, platelets, etc., to the site of an injury. And we talked about that particular concept a lot in almost every disease state where, this capillary permeability allows for an inflammation and other issues that are beneficial and can be pathologic. And one of the things we talk about is the inflammatory immune response. And this is our innate immunity. The purpose of that is to control bleeding. That's one thing it does. It removes waste products, limits infection, and it promotes healing. It does local vasodilatation. That delivers increased blood flow to bring in neutrophils, macrophages, and clotting factors to damaged area. Results, though, are edema, redness, heat, and pain. Those are all your signs and symptoms of inflammation. Serious injuries, sustained response can damage vessel in the area of the injury, so that can be a problem. Prolonged responses can cause an increase in permeability of the capillaries, and that's where it can become pathologic for these patients. So we'll talk about one of those pathologic findings, and that's systemic inflammatory response syndrome, or SIRS. So you get this insult that occurs to the body, and that leads to this uncontrolled inflammation in multiple organs that are far from the area of insult. So it's an overwhelming self-defense mechanism. Increased activation of the inflammatory cells, such as neutrophils, macrophages, lymphocytes, and damage to vascular epithelium, deterioration and distribution of nutrients to the organs, and that's what ends in multi-organ failure. It ends up with that. Some of the causes can be infection, pancreatitis, ischemia, trauma, hemorrhagic shock, aspiration of gastric contents, very damaging, massive transfusion, and host defense deficiencies. So again, this is just kind of pictorial graph of what happens and all the multiple layers of this when SIRS happens. So that continued inflammation, why? Why do we continuously get this inflammation? Why is it continued? Well, it's failure to control source of the inflammation or the infection, persistent hypoperfusion due to prolonged shock, not just hemorrhagic shock, a lot of shock states, presence of necrotic tissue, abscesses, or altered cellular oxygenation consumption. That hypermetabolic state that you see in burn patients is a classic example. So what actually happens in the body? Well, you get this intravascular inflammation and that increased vascular permeability that we spoke about so many times. Hypoxia, it's from damaged blood vessels. You get anaerobic metabolism due to hypoxia. So you form lactic acid, and it's a byproduct of that glucose metabolism. So we can measure that. That becomes very important later on. Muscle fatigue, and they get a failure of the sodium-potassium pump due to this metabolic acidosis. So it allows sodium to enter the cells as potassium leaves, and fluid follows sodium into the cells. So the cells swell, and you get this release of intracellular enzymes, and the cells can't function anymore. So it's a breakdown at a cellular level. And calcium also enters the cell, and it blocks phosphorus, stopping ATP. We need ATP for energy. We know that. That is an integral part of every cell. What happens inside the body? Those cells burst, and they die, and it releases potassium into the bloodstream. So again, there's quantifiable things we can measure for these patients: lactate levels and potassium levels. And we know that if they're elevating, things are getting worse. And if they're reducing, that almost lends to some of our treatment modalities being successful. So they are hyperkalemic, which can lead, as you all know, cardiac dysrhythmias and muscle weakness. And that neuroendocrinologically, the response is the release of catecholamines, which is a sympathetic nervous system response. So you see all the things that go along with the sympathetic nervous response release: increased heart rate, cardiac output, metabolism, glucose, activation of platelets, prolonged catecholamine release. You get hyperglycemic, and they get insulin resistant. Then cardiac dysrhythmias follow, and the release of adrenocorticotropic hormone and cortisol, which increases glucose levels even further. Get vascular constriction and the release of mineral corticoids such as aldosterone. Again, aldosterone causes the reabsorption of sodium water, hence now more edema, and it caused by fluid loss, so interstitial spaces or hemorrhage. So again, continuing on, what's the renal response? Well, they get hypovolemic, leads to the renin, angiotensin aldosterone system activation, again, potent vasoconstrictor, and aldosterone reabsorbs sodium and water. So we get an increase in blood pressure. That kidney reabsorbs the sodium, water follows, so we increase volume. And then we excrete potassium. That antidiuretic hormone secreted, so we water absorb and we hold on to that. We get a decreased urine output. So we need some certain requirements to actually diagnose SIRS, and it's defined as 2 or more of the following variables. 1, if they have a fever more than 38 degrees centigrade or 100.4 degrees Fahrenheit, or the opposite extreme. Are they hypothermic? Is it less than 36 degrees centigrade, which is less than 96.8 degrees Fahrenheit? They need to have a heart rate more than 90 beats a minute. And this is interesting because it's not tachycardic. It's more than 90 beats a minute. Again, tachycardia is over 100. A respiratory rate of more than 20 breaths per minute, or arterial carbon dioxide tension of PaCO2 of less than 32. Again, those go hand in hand. If you're breathing faster, you're blowing off more carbon dioxide, so it drops. Abnormal white blood cells, if they're greater than 12,000 or if they're less than 4,000, or greater than 10%, these immature cells are called bands at a bandemia. You know, they're pumping out, they're trying to keep up with whatever innate defense mechanism that body is doing, and they can't. Those mature white blood cells get used, so they start increasing production of these new ones, these bands, and they form. We can measure those. So the treatment for this would to treat the cause, that's the main thing, and then you treat hypotension, fluids, and vasoconstrictors. And we spoke about that with shock last week. So sepsis is simply SIRS with an infection. So you have all the things of a systemic inflammatory response syndrome, and then you have an infection that's overlying. And that Venn diagram below just shows that. You get sepsis, and it can be broken down into 3 different types. So sepsis is SIRS plus infection. Severe sepsis is sepsis, but you get some end organ damage involved. And then, of course, septic shock, which is severe sepsis plus hypotension. They kind of build on each other. We saw that there. So again, SIRS resulting from an infection, sepsis with the acute associated organ failure, persistently low mean arterial blood pressure as a result of overwhelming infection despite adequate resuscitation of septic shock. Then you can have a refractory septic shock where it's just persistently low MAP despite vasopressor therapy and adequate fluid hydration. We're treating them, but they're not responding. Let's talk a little bit about sepsis. It is a systemic response to an infection that involves SIRS and results in endothelial dysfunction and altered arterial circulation and coagulation. So the most common causes are gram-negative bacteria, like our friend over there in the right corner, E. coli. Microorganisms, toxins, secrete endotoxin that stimulate capillary permeability, again, fostering all of what we talked about with the edema. They get hypotensive, hypoperfusion of organs is the end result of that. Sometimes the result of infection is never found. We know they're septic, but we can never find what the root cause of it is. Idiopathic. Severe sepsis is associated with organ dysfunction, as we discussed just a second ago. And hypotension is that septic shock. Again, a systolic less than 90 or a reduction more than 40 millimeters of mercury from baseline in the absence of other causes of hypotension. So we've ruled out all those other causes. There's an article here, which is pretty interesting. You can read that on your own time about maybe we should keep these patients hyperthermic, let the fever run its course. So we're so quick to treat that what's better, treating it or having it go higher. So sepsis, again, when we look, our normal body temperature, 98.6 degrees Fahrenheit, about 37 degrees centigrade. And fever is a very common symptom, but it might be absent in patients who are elderly or immunocompromised, immunosuppressed patients. The hypothalamus kind of resets in sepsis. So the heat production and heat loss are balanced in favor of a higher temperature. So it likes that little bit of hyperthermia. Inquiry for us as nurses is find out about it. Was it abrupt? Was it gradual onset fever? How long did it last? What was the highest temp it got? And these features have been associated with increased infectious burden and severity of illness. However, fever alone is not a very sensitive indicator. It's insensitive, actually, of sepsis. In fact, hypothermia is more predictive of illness, severity, and death. It's kind of interesting. So urosepsis is something that we find common in our patient population because it's more frequent in older adults. Increased use of catheters in long-term facilities, Late detection of UTIs. They have decreased sensation, burning, urgency, all those things that we have taken for granted as our youth that, oh, I got to pee. They kind of neglect those. So what are some of the signs and symptoms of urosepsis in the older adult? If they're not having those early ones, and one of the big ones is confusion, altered mentation. If there's acute altered mentation, we might want to start poking around, and then you have foul smells. You can look at the urine. You can look for cloudiness, any pungency to it, and we can also send it for urinalysis. But in that elderly population, we look at their mentation too. How do we treat sepsis? Well, we have a bunch of goals when we treat sepsis. So we need an antibiotic. The most common cause of sepsis is gram-negative bacteria. So our national patient safety goals say, look, give an antibiotic effective against gram-negative bacteria within an hour diagnosis. You got ceftriaxone up there to the right. So, vancomycin is another good one. We know that it attacks these, so high likelihood it is one of those. Let's start them off right there within an hour of diagnosis. Then the resuscitation phase. So we correct hypoxia, hypotension, and impaired tissue oxygenation. All that hypoperfusion we need to fix. Fluid resuscitation, we give them vasopressors like dopamine, norepinephrine, and epinephrine. Dobutamine increases the strength of that cardiac contraction. We discontinue the vasopressor if the patient begins to complain of chest pain. And we spoke about that last week. Again, it increases MVO2. It's increasing myocardial oxygen demand. So if there's a case that you're giving a medication and they're having a side effect of it, that can be more detrimental than the medication's beneficial. Okay, identify the source of the infection. So antibiotics, surgery could be the root fix for that. Maintain adequate organ system function, guided by cardiovascular monitoring. Stop the progression of MODS, multi-organ dysfunction syndrome, which we'll talk about. And there's a thing called Surviving Sepsis Campaign, and it's all about bundles. And you can look at this here. Sorry, my dog is just moaning away in the background. Give me a half a second here. And that, sorry about that. So the Surviving Sepsis Campaign and these bundles, we know that bundling care helps not only just sepsis, but there's a lot of different avenues of medicine that we know we can bundle this care. We get really, really better survivability and decreased mortality and morbidity in these patients. All right. There we go. Okay, so sepsis bundles. The last text, if you're familiar with that, stated 3 hours. The current is an hour. So within that first hour, we want to measure a lactate level. Again, we know that we can measure that because we can actually track that. Obtain blood cultures before administering antibiotics. Administer broad-spectrum antibiotics, as we said before, that against the gram negatives. And a rapid administration of 30 milliliters per kilogram of crystalloids for hypotensive or lactate greater than 4. So at that point, we know we're kind of behind the 8 ball with these patients. And apply vasopressors if hypotensive during or after fluid therapy, and maintain a mean arterial pressure of greater than 65. And this here is all the latest evidence. We know that fluids, when we give it, we want to give a colloid or crystalloid. We're not giving starches. We're not giving high chlorides. We get early antibiotics on board and vasopressors 1 to 6 hours after onset. And again, these medications like norepinephrine, which is Levophed, and epi drips and vasopressin drips that we would hold off until the very end, we know now that getting them early and aggressive is much more beneficial. We start enteral feedings. We want that nutritional therapy. We want insulin therapy because we know that there's a high correlation between hyperglycemia and bad outcomes of a lot of disease states. We really withhold deep sedation. We want to keep them maybe lightly sedated. Molecular targeted therapies, again, all these new advancements that we have. And we have lung protective ventilation. Again, one of the things that can happen with sepsis is that in that MODS area is ARDS, acute respiratory distress syndrome. So let's get on the forefront of that. We have a catheter that we can monitor urinary output. Some of them have invasive temperatures. We measure core temperatures with them. But it's very important that we measure their urinary output because that helps us guide our fluid resuscitation therapy. We stop this early goal-directed therapy and goal-oriented therapy. So those are all not in favor anymore. So let's talk about that ARDS. And we spoke about it in week 5. We talked about high-flow nasal cannula, may be beneficial in patients with ARDS, alternate to intubation and mechanical ventilation. And it's associated with nosocomial pneumonia and barotrauma when we do mechanically ventilate those patients. So the high-flow nasal cannula is heated humidification of this oxygen via large bore nasal prongs to deliver oxygen, sometimes up to 50 liters a minute. It's usually well tolerated. It allows the patient to talk, eat, and even move around if need be. So it's pretty neat. Moving on to disseminated intravascular coagulation or coagulopathy. This is one of those disease states that might ring a bell in you. You've heard about it in pathophysiology and maybe even some other courses, but it's characterized by systemic activation of blood coagulation and then overstimulation of the clotting cascade. So it results in deposition of fibrin, leads to microvascular thrombi in various organs, and it contributes to multi-organ system malfunction. It's a really, really fickle disease state because you use up all of your clotting factors, and then you have none. So then you bleed. So that's the hallmark of it. It's all of this clots and bleeding at the same time, bleeding from everywhere. So you get these intravascular thrombuses from all this clotting cascade, hypoperfusion of organs, ischemic damages, and then since they're all used up, you can't form stable clots, so they bleed. Then there's a secondary activation of thrombolysis, which is a release of anticoagulants, which further adds to the bleeding problem. When you consume all of those coagulation proteins and platelets, and this severe bleeding happens, and they bleed from every and any possible orifice. Excessive clotting depletes all those clotting factors, and much more than the liver and bone can replace them. And the blood clots cause that hyperperfusion of tissue and organs and leads to ischemia, while anticoagulants release and dissolve the clots triggers hemorrhage in other locations. It's such a difficult disease to initially manage. So the sudden hemorrhages to the tissues beneath the skin and mucous membranes produce bruises or petechiae, and the patient with DIC can present with simultaneous excessive clotting and hemorrhaging. That's the hallmark of it. Microvascular clots impair circulation. That happens in the kidneys, lungs. They can get ARDS. Cells die. They release mediators that activate this whole inflammatory process. You get hypoxia, acidosis, and shock. And the systems that are really affected are the skin, lungs, kidney, CNS, and GI system. The severe bleeding, they get strokes, lack of blood flow to the arms, legs, and organs. It can be a very devastating disease and very, very difficult to treat. We know that causes really can be anything that causes prolonged bleeding or intensive volumes of blood loss. So it's associated with trauma, tissue necrosis, burns, septic shock's a big one, some viral, that should be viral, bacterial and protozoal infections, respiratory and cardiogenic shock states, hemorrhaging during pregnancy. That's where you might have heard of DIC is in mother-baby. Obstetric complications such as abruptio placentae, retained products of conception, heat stroke, and some snake bites have massive anticoagulant capabilities, and it starts this DIC process. Laboratory findings we expect to see are decreased fibrinogen levels. They're not using fibrin to make clots. Decreased platelet counts, increased PT and PTT time, increased D-dimer. Again, they're having a bunch of clots, and they're also degradatory products of that. And an increase in fibrin split products, also called fibrin degradation products, FDPs. We assess these patients. We observe all drainage for blood, GI, mucous membranes, eyes, nose, and mouth. We check for petechiae and purpura. Petechiae are the small ones in the lower right there, and purpura are the larger bruises underneath the skin. They're non-blanching. So there's some early symptoms of hemorrhage. They get hypotensive, tachycardic, decreased loss of consciousness. So we avoid sharp objects, obviously, and we avoid IM injections at all possible. So how do we treat it? Well, first, if we can address the underlying disorder, if we know it's septic, if we get them an antibiotic that's effective to it, evacuate the uterus for an abruptio placentae. If that treatment's effective, we know that DIC kind of subsides relatively quickly. We replace the fluids with crystalloids or colloids, and then we have possible replacement therapy. They've used up all their clotting factors, so let's give them clotting factors. That's your FFPs, cryoprecipitate. Other blood products might be given. They might be getting packed red blood cells. They might get plasma, so they might get platelets. So there's all these other things that we can give them hematologically. We consider giving a heparin. Again, if it's obstetrics, they usually refrain from heparin. It inhibits the conversion of prothrombin to thrombin, so we use it in early DIC. And it inactivates circulating thrombin, so it inhibits the conversion of fibrinogen to fibrin. The whole goal of this is to prevent new clots from forming. That's why we're given the heparin. All right, so DIC is a fun, fickle disease state, which can lead to MODS, multi-organ dysfunction syndrome. Again, it's called MODS. You may hear MOF, multi-organ failure, or MSOF. I had a little disagreement, not a disagreement, it just brought it to the attention of the national course lead, because in your course it's labeled as MOFS, M-O-F-S, but it only talks about MODS, and I didn't want there to be a confusion that there were separate disease states, so hopefully they're going to fix that typo for you. But MODS is really what we're thinking of, multi-organ dysfunction syndrome. So when shock conditions continue for long periods of time without treatment, the resulting metabolites that are released in the body cause so much cell damage to vital organs, they're unable to perform their critical functions. Injuries that require a large amount of fluid resuscitation, such as shock and burns, are really, really at high risk for MODS. Appears to be doing well for a very short period of time, and then boom, the systemic inflammatory events happen. They get a low-grade fever, tachycardic, dyspnea. They get increased neutrophils and white blood cells, elevated glucose levels, pulmonary infiltrates, renal and hepatic dysfunctions. So it can develop from severe hypotension and reperfusion of ischemic cells, causing further tissue injury. Inadequate tissue perfusion can cause organ failure, especially in the lungs. That's our ARDS patients, acute respiratory distress syndrome. Kidney, you can go to kidney failure. And the heart, decreased coronary arterial perfusion. You can get decreased cardiac activity and contractility. You can get dysrhythmias that can happen, extrasystoles, and the GI tract, they can actually become necrotic, which sets off a whole series of other inflammatory responses. So our nursing actions are to assess those organ functions. Look at the signs and symptoms, look at the skin, look at the urine output, look at the cardiac monitor, provide support measures that can increase tissue perfusion and improve organ function. That's ventilatory support. That's inotropic medications. That's our pharmacology and our medical devices of the world that can augment this. Implement measures to compensate for dysfunction. That's administration of clotting factors, getting them dialysis, etc. We as nurses will have an important integral part with these MODS patients. So what signs and symptoms would you expect for a patient going into MODS? Lungs? Well, again, you think of ARDS. You're going to have hypoxia, dyspnea, tachypnea. Again, that alveolar membrane capillary interchange is ineffective. They're getting 100% oxygen, but still have low SpO2 or SaO2. They may be respiratorily acidotic. What about the kidneys? We're going to have low urine output is an early indicator. We're going to assess the labs for increasing BUN and creatinine. And they become completely anuric after a period of oliguria. Cardiac, we look for cardiac dysrhythmias. We look for poor cardiac output. We look for pulses, blood pressure. These are things we can manage. Capillary refill on your patient that becomes delayed. And GI tract, we can assess bowel sounds. Are they hypoactive? Are they absent? Are they having stools? Are the stools liquid? Are they hard or not there at all? So renal dysfunction in MODS, again, evidenced by creatinine levels greater than 2 milligrams per deciliter, urine output less than 480 milliliters in 24 hours. That's not a lot of urine. And, of course, dialysis is required for these patients. There's a difference between a primary and a secondary MODS. So it refers to progressive organ dysfunction in the acutely ill patient, such as hemostasis cannot be maintained without intervention. So the primary MODS result of a well-defined insult in which organ dysfunction occurs early and can be directly attributed to that insult itself. Renal failure due to rhabdomyolysis. We know that. That's an intrarenal problem, and that's a primary MODS. Secondary is an organ failure that's not direct response to the insult itself, but the consequence of a host response. So acute respiratory distress syndrome in a patient with pancreatitis. It's not directly caused by it, but it's an indirect consequence of that initial insult. Again, looking at this, talking just about shock here, low blood flow, maldistribution blood flow, so cardiogenic, hypovolemic, neurogenic, anaphylactic. We went over all of these last week, but they can signal and start that systemic inflammatory response syndrome, and then all these cytokines and interleukins and radicals are out there, endothelial tissue injury, and vasodilation, increased permeability, edema, neutrophils, and that leads us to MODS, where we start to target different organs from cardiovascular all the way to skin and everything in between. Populations at risk are those potential sepsis and organ failure, environmental, chronic illnesses, hypersensitivities, immune function, autoimmune diseases. So these are all populations that are at risk for systemic infections, potential sepsis, and organ failure. People with wounds, burns, and trauma. Secondary opportunistic infections can rapidly progress to sepsis in very young, preemies, and elderly, again, at-risk populations. And those with immune issues, underlying infection, addiction, smoking, malnutrition, anemia, and hepatic diseases. And that is a really quick Module 8. Yeah, it just had over those that we didn't want to kind of lump in with Module 7 last week. With that being said, ladies and gentlemen, that is not a very long module this week. So take a deep breath, study up. There's the recorded review. I encourage you to listen to that. And best of luck on not only your ATI, but next week's exam. I feel like I won't see you, but I will see you. Next week's exam is on campus. And this is Module 8, so the code word of the day. Let's see. How about you tell me your favorite part of nursing school? Because we all know and hear the worst parts of nursing school. I want to know your favorite part of nursing school. Was it meeting a friend? Was it learning something new? Yeah, let me know that. That's your code word of the week is what's your favorite thing about nursing school? You might have to think about that for a little bit. All right, have a great week, everybody.